How many federal employees are here? Oh, good. Keep your hands up. Very good. Thank you. I'm new to federal service. I've been here 17 months. When I get to the years, then I can start talking about it in terms of years, but still like a toddler. And when I moved from Texas, and I've spent, except for my college time spent in New York, I've spent my whole life in a 100-mile radius of my hometown. And so when I came to the DC, people said, there's going to be an incredible culture shock. And I said, well, that's true. And now, 17 months later, I'd like to report that it was true, but you seem to be getting over it. So I want to say thank you very much for that. I do want to tell you a little bit about my history. When I started in computer science, I actually had a degree in pre-med in English, didn't know what I was going to do, but was an accidental programmer, hired as a biostatistician at an institution in Dallas, Texas, that treated cancer, childhood leukemia. It was the only place in Dallas where you could go. And they had a computer installed in 1969 when the hospital was built. And they had no medical records department whatsoever. Because the dream then was that you could actually take all of the information from this 110-bed hospital and put it on a computer system and use it for the reasons that we are trying to do computerization today. Of course, there's no way that really was possible. The computer that cost $1.5 million had 20 gigabytes of disk capacity. But still, 7 years later, after replacing the machine, we actually did create electronic health record. But it was my first experience, my first program that really changed my passion for what I was going to do in life. And I was able to look at the in vitro laboratory results from microbiology. And most patients didn't die from the leukemia or the cancer, they died from infections. And we were able to take the in vitro results for a group that was immunosuppressed. These people had tried everything in their battle to defeat cancer. And the results that they were getting were significantly different. They had different reactions. They'd been over-medicated. And so if you did what the literature suggested, the patients were going to die because you didn't get them on a regimen quickly enough for antibiotic therapy. And this program, very simple, something any first-year programmer could write, looked at the results and suggested treatments based on the amount of information that was known about the patient or about the organism. And when it was completed, for the first 20 patients, I was very studious and very worried about what the results were. And in 20 out of 20, the first 20, the results were right on target. Contrary to what was suggested by the literature, we put them on the regimen that was suggested by the computer, and every one of them, that was the right treatment. Okay? So, huge awakening. It's like, oh my God, what kind of transformation can occur? Now that was in 1972. So the question is, in 2013, why don't we have people doing this? Just 3 years ago, only 17% of physicians had a computer in their office, or computer records in their office. They all had records to do billing, but they didn't have records to do what they went to college for and spent many years after college. So the question is why? It's because the market wasn't encouraging to do what they needed to do. The prices weren't there, the features weren't there, the design wasn't what it was supposed to do. So the reason I joined the government is because I believe so strongly that when the market is not operating properly, the government should intervene on behalf of the patients. And this really is all about patients. And we'll talk about providers, but we'll end with the patients. So together, and that's everybody in the room here, you're either a care insurer, a care provider, or a care user. So everybody is going to be involved. We need to do care transformation. We need to get the patients involved, and more than just involved, active. We talk an awful lot about the providers, and the stimulus package that we're putting together, we'll talk about in a minute, really focuses on the providers, but the patients is what makes the difference. If I give you all the tools, but I can't get you as a patient to use them properly, the result is going to be the same. Huge investment, wasted. So we'll focus on the patient, and we'll talk about population management. Now, Does anybody know about meaningful use? Have y'all heard the term meaningful use? Raise your hands if you. Okay, this is what we call the program. We want people to be meaningful users. So I'm going to explain meaningful use in non-technical terms. Okay, so everybody can see this is a pumpkin. This is the meaningful use of pumpkin. Okay. It's appetizing, it's attractive, and it's digestible. Okay? There's some parallels between what we're trying to do with health information technology and data to meaningful use. The meaningful use program was actually funded with $22.5 billion in 2009. And it was part of the High-Tech Act, Health Information Technology for Economic and Clinical Health. Bless you. The requirements were pretty simple. You had to have a certified electronic health record. You had to be capable of doing electronic prescribing. Bless you. You had to be able to exchange health information. That's probably the most critical part that will benefit more people than anything else. And you had to be able to report on clinical quality. And we've done this in 3 stages. So you'll hear us talk about stages of meaningful use. They said to put this out to the side. Prayer. Prayer works. I came from a faith-based institution prior to the government. In terms of administration of programs, CMS, any members of CMS here? There are thank you very much, significant partners. They help administer the stimulus program. ONC, the Office of National Coordinator, defines the standards and criteria. The Office of Civil Rights, anybody here from OCR? Bless you. A lot of sneezes in this already. You from OCR?
For a different agency.
Oh, well, I'm glad you're here, regardless. But the Office of Civil Rights has to make sure that the HIPAA regulations are going to be able to keep up with the technology, so a joint effort. We talked about the $22.5 billion. There's $2 billion that we also got that's going to expire within the year that we were able to spend on all these activities, which all deserve much attention, but I won't pay attention to them. Then $10.3 billion from other federal agencies. But it pales in comparison to what is being spent in the private sector. When I was at 2 previous institutions, the stimulus money was going to be 1/6 of what it was that we were spending to actually install electronic health records. For physicians, it's about $44,000 a physician, or $63,000 if you happen to be a Medicaid physician. It's enough to cover the initial investment, but it doesn't keep up with the ongoing, so obviously you need to make sure that you are doing the right things with it to save money. Now, the thing that I think is more important than meaningful use is actually the meaningful conversations that should precede implementation of any technology. And I used to be the Luddite CIO. It's like, don't use technology if there's any other solution. Okay, I think it was Churchill that said the Americans, you can always count on them to do the right thing after they've tried everything else. Well, it's the formulation of the question, the experimental design, that really is critical. And when you're implementing technology, you need to ask why you're doing it. You're not just buying the iPhone because Sally or Johnny bought it. It's because you love music, you want to talk to your friends. Those are the kind of conversations. And the thing that's really tough is change is not simple for people to go through. Now, I love this. I try to use this with my wife and children. Change is good, you go first. It gets the kind of reception you're giving me. Thank you. But the fact is that people get disgruntled when you upset their workflow. If you ask anybody who's in the medical field to identify themselves with 3 words, I guarantee you that their role in healthcare is going to be one of those 3 words. And now as a CIO or as a government official, I'm coming in and I'm saying, we want you to change the way you've been doing things. That paper thing that you've been doing for so long, we're not getting the results we want you to change. Now I'm not just attacking who they are, what role they have, I'm attacking who they are and how they identify themselves. So these conversations are very tough. And I put workflow up here because that focuses on the providers. But the most important word up here is life flow, because we've got to get the patients to make the changes. If we get one wheel spinning, and then we're able to get the other wheel spinning, but they're not spinning in sync, we'll have the technology deployed, patients won't do what they're supposed to do, we won't get the outcomes that we want, either financially or... Now, if you or your organization is represented up here, could you raise your hand? Okay. Everybody who's not got their hand up needs to thank these people. These are the federal partners who are working together to make this a reality, to get electronic health record and health information technology dispersed quickly. So it's not easy now. What do hockey and EHRs have in common? This is a real stretch. Okay, it's the shape of the, I'm sorry. It's the shape of the stick. Okay, I'm really more of a stretch than it should be. I'm going to share with you some of the successes, and then I also want to share you some of the challenges. But if you notice the shape of these curves, they're very much like hockey sticks. This is a leading indicator. You have to register for the program before you can attest, before you can receive the money. So great leading indicator. You can see that more than 74%, that's of the 522,000 physicians, are already registered. Okay, the eligible hospitals, easy to see. You can see here, we've passed the 50% mark. Very happy about that. We're nearing the 80% mark with hospitals in terms of people who are actually attested and receiving money. In terms of the amount of money, of the $22.5 billion, actually $14.6 billion has now been distributed. There's some controversy about that. I think it's good. If you think about the amount of money that's being used by the private sector, then the government's participation in this, I think, is really important. So it's good that we're helping. In terms of adoption, this is a very interesting graph. People say, well, the old guys won't do this. I won't tell you which color I am, but it's not one of the top ones. And you will see there that the curve of adoption is exactly the same regardless of which age cohort you're in. So make sure that if you're going to know a physician, you're asking him or her why he or she is not participating in the electronic health record program. They can adopt at the same rate the rest of the people. In terms of e-prescriptions, 92% of all prescriptions written in the United States are sent via electronic network. It's huge. Over 50% of those are generated by electronic health records, and that number is growing. This is a curve that looks good. I'm a little worried about it. This is the number of vendors who've come onto the market, and the question is, will they survive? We had a very good partnership with the Electronic Health Record Association yesterday, who put out a code of conduct that says we who are going to be receiving the seal are willing to help you transport your data from one system to another. So this curve was less worrisome today than it was yesterday. In terms of job postings, we heard about that earlier from one of the previous speakers. Need to get more people trained. The number one profession across the board, according to the Department of Labor Statistics, is health IT jobs. It's growing at a rate between 2009 and 2018 at 20%. It's huge. So opportunity-rich environment for those of you who are sending children through. We are doing our best to try to get some trained. We've trained about 22,000, some in the community colleges, some in, but it's not even close to enough in terms of whether the health IT industry is having, remember high-tech is economic and clinical health. Are we having an impact on the economy? Absolutely. $17.9 billion spent, according to one estimate, which has now grown to $20.7 billion, and in the European Union, $6.8 billion. So opportunity-rich environment. Now, does this remind you of a patient or a consumer? Didn't remind me either, but I love the picture. So, but we need to talk about that. It used to be that the medical code of ethics for the AMA, American Medical Association, would not allow a patient to participate in their care. It's unbelievable. Nowadays, they've reversed that completely. Patients share the responsibility for their own health care. Of course they do. The physician can't dictate to somebody what they're going to do in activities of daily living. So we now have these programs that we're trying where we're trying to encourage people to do this. And the comment down here is very important. When I check my own medical record, like this guy has done, I found record inconsistencies. The data was wrong. The guy who'd actually done the prescription wrote down the information incorrectly in my chart. Prescription was right, information in the chart was wrong. So I'm trying to get everybody to get engaged here, so I want you to be active patients. Ask and check and ask. Patients need to think about acting as custodians of their data. Right now, the physician or the hospital is the custodian of your data, but everybody in this room has a right to the data. You just don't necessarily have a right to the paper on which it was recorded. Okay? With personal health records, which now allow you to gather information from these charts, you should be able to be the custodian of data, which is a great idea. One of the things that we have in the next stage of meaningful use is that every patient has the ability to view, download, and transmit data to the source or to the origin of their choice, or the source of their choice, destination of their choice. Really big deal. So we want you to put your health in your hands. Here's devices that you can actually ingest, wear, that are publishing data all the time. You want to be able to gather that and report it. We have homes that now talk and watch for ambulation. I have a person who has a father in Hawaii. It calls him when his father's not moving. Cars now have sensors. Wouldn't it be nice if I was driving down the road, my blood pressure went up, and the radio said, "Excuse me, let me change the station to easy listening. You're obviously stressed." The FCC just passed what's called, or created a thing called an M-band, Medical Body Area Network, because we're wearing devices that are now generating data. I have one on my arm. I'm sure many of you carry equivalents of the Fitbit. We want you to be able to access the data, take action, change your attitude, and we show clearly that if the patient gets engaged, the outcomes are significantly better. What's really horrible is this next slide. It shows how pitiful it is. Okay? I can tell you that when I walk by my mirror, I see a 19-year-old boy every day. Or I'm thinking that's what I'm going to see. It's not what actually happens. The Veterans Administration, any veterans here? Veterans, not VA people, just veterans. You can now download your information directly into a device that you carry. It comes down in a PDF. There are programs out there called iBlue Button that let you convert that into charts and graphs that you can share. Go out there and look for Blue Button. Just a reminder, we're very sensitive to this. Security and privacy didn't get mentioned this morning, but privacy is a key and should be in the DNA of everything we're doing. In terms of innovation, we keep thinking about it in terms of technology. Look how long it's taken for 1 million units of these particular devices to become available. Okay? Right now, the chart that's not up here is how long it takes for information that is learned to actually be distributed to become part of medical practice. It is at 17 years now. Okay, and we're creating data where we can learn things. We've got to figure out a better way to incorporate it into our lives. Okay? So liberating data, it's the key. We can change the patient care, we can change population care, we can change the planet. Okay, and it's going to be the efforts of everybody here who's going to help. Now, it's always important to end with a real-world example. And again, I was at Baylor Healthcare System. I had the responsibility or the privilege of overseeing people who installed electronic health records in both the inpatient, outpatient setting, and provided personal health records to our patients. So I got to see it work. Here's a 59-year-old woman who was diagnosed with glaucoma. And so she was taking a beta blocker for her eyes. That's part of what you have to do. She wasn't just smoking dope. She was actually taking a beta blocker. That is an alternative way to deal with this. And then she's from Oklahoma, so on April 15th, because her son is a nationally ranked triathlete, she decides she's going to do a little mini triathlete with her daughter. She jumps in the water, 10 minutes into the swim, has a heart attack. It's confirmed on diagnosis. But I said she was from Oklahoma, so what do people from Oklahoma do? Shake it off, so she finished the water. Her son was waiting there. She looked terrible. He took her out, made her stop. She went over to a Baylor facility, okay, and was admitted. And when she was admitted, they passed out a sheet in the admissions process that said, here's the potential issues that you have. Here are all the procedures that can be performed, and here's the risk profile for you as the individual. 59-year-old woman, this kind of body shape, this kind of laboratory. So the patient's family were gathering around, and rather than having questions that are terrible, you're able to see a chart that says low probability of mortality, low probability of mortality, and encourages and gives hope to the family. She goes down, she has an angiogram done, angiogram comes back, the physician comes in the room, actually pulls up the records on the computer, says, I have some great news for you. You have the body of a 30-year-old, and you have the coronary arteries of a junior at Plano East High School. Well, of course, everybody is relieved. You had a non-STEMI event, but it looks like there's no permanent damage. We just have to figure out how to take care of you. I'm going to put you on a beta blocker, and up on the computer screen says, oops. From what was gathered in an ambulatory record, we see that during medication reconciliation, you were already taking a beta blocker. We've got to figure out a different medication, avoided a potential deadly problem. And so when she left the hospital, they handed her personalized discharge instructions, and nobody listens when a doctor's talking as you're getting discharged. The family can't remember, the patients can't remember, so go home with all the information they need. And then she had a good event. So things have been wonderful. And by the way, the reason this isn't so important to me, it's not just because this was done at my institution. This is my wife. Patients are not averages, okay? She is a quality person, and this is what she keeps reminding me about. So I want you to all connect, communicate, and collaborate, okay? We can make a huge difference. And I'd like to thank everybody who's a part of the federal service, all those people who are helping all us feds make a difference in everybody's lives. Thank you.